Our next speaker is U.S. gastroenterologist Ralph McKibbin. Dr. McKibbin is a practicing gastroenterologist in Altoona, Pennsylvania, and he is the past president of both the Pennsylvania Society of Gastroenterology and of the Digestive Disease National Coalition, also known as DDNC. Dr. McKibbin is also the chairman of the Alliance for Safe Biologic Medicines, known as ASBM, which is co-sponsoring this program. He has written extensively on the issue of non-medical switching and other insurance industry utilization management techniques that can negatively impact patient care. Today, he will share survey data that ASBM has gathered over the past few years from physicians in 13 countries, looking at how physicians prescribe biologics and biosimilars. What's especially interesting is that while the healthcare systems of all of these countries and policies surrounding biosimilars are very different, the world's physicians are generally in broad agreement, especially on the importance of physicians and patients maintaining control over treatment decisions rather than a third-party payer.
Hi, I'm Dr. Ralph McKibbin. I'm here today to talk about physician perspectives on biosimilars. I'm a practicing gastroenterologist. I've been in practice for more than 30 years in central Pennsylvania, and I'm still active. Over the course of my practice, I've also been involved in the process of change in organized medicine. It's important when taking care of patients to make sure that the processes and procedures around them are helpful. So I'm past president of our Pennsylvania Society of Gastroenterology. And on the national level, I've been involved in the Digestive Disease National Coalition as past president and through the American College of Gastroenterology. Currently, I serve as chairman of the Alliance for the Safe Use of Biologic Medicines. The ASBM was formed in 2010 with the passage of the Affordable Care Act and Biosimilar Price Competition Innovation Act. But the idea is that we are keeping patient safety at the forefront of biosimilar policy. Biosimilars are going to be discussed throughout this forum in different ways, but today we're going to talk about the physician perspective on the use. The ASBM is comprised of a bunch of stakeholder organizations, more than 130, many of which are patient care groups, but also physicians, researchers, and manufacturers. Those who are advocating and out in the process of change know that talking to stakeholders is important. And of course, with our triple aim, patient or person-centered care is priority here. So getting the physician perspective helps all of us discuss how to safely use medications. As part of this endeavor, the ASBM has surveyed physicians over the last 10 years, 2012 to 2022. And you can see the US physician surveys listed in the upper left, Canadian physician surveys, but also around the world, European physicians, including France, Italy, Germany, Spain, Switzerland, Latin American physicians, Argentina, Brazil, Colombia, and Mexico, and Australian physicians. We all have different perspectives. Some have used biosimilar medications longer than others. So that helps us to determine trends and help share experiences around the world. These surveys are available on the website. We can talk about that later. So who has been surveyed? Well, if you look at the specialty of those who have been surveyed, allergy, immunology, and these are in alphabetical order, dermatology, myself, gastroenterologist, endocrinologist, we all have immune diseases, which are the primary diseases treated by biosimilars. And it's an equal amount throughout the surveys, more or less. So we have a broad perspective of different patients and practices, and also different years of experience. So we have about the average experience level of about 20 years. It's important when looking at this also to understand that all physicians are not created equal. Those with lesser experience, more experience, have different patient populations. Some of us treat the elderly, some of us treat children, men, women, urban, rural, so that our perspectives are different and diverse, not just in our years of experience, but in our patient populations. So surveying across those populations gives us a true view of what's going on. When we get these perspectives, we can then share them with regulator organizations. The ASBM is presented to the World Health Organization, which of course is a global organization. national organizations, as noted on the bottom, the FDA, the EU Commission for EMA, biosimilars meetings, et cetera, Health Canada, international conferences on drug regulatory authorities, et cetera. So these surveys and data are shared with regulators, so they have a perspective on what's going on. You as advocates also need to know what's going on in patient practice and in the minds of physicians. So some of the issues examined in these surveys are listed here, but what we want to do is focus then in today's meeting more on substitution and switching of biosimilars. And we'll get into that, specifically what switching means and substitution. Who's deciding this, and should we have more information before we can make a clear-cut decision on who's doing it? So as it stands, if you look at the surveys listed here, Canada, the EU, and the US over the last few years, actually coming up on 5 years now, there's confidence in the idea of prescribing biosimilars. The idea of biosimilars, which are not generics, but very similar to the innovator medications, is that we could perhaps lower cost and increase accessibility for patients. And so physicians are confident in the use of these for new patients. If a new patient comes in, we'll do it. The question then is, what about patients with different problems or past experiences? Treatment plans are not universal. As I said before, patient practices are diverse, and so are patients. Many patients, as an example, I'll use a concrete example from my practice. Patients with Crohn's disease may have an 8 to 10% chance of having a second immune disease, rheumatoid arthritis, lupus, et cetera. So you're maybe not even treating just one disease, you're treating multiple diseases, and prior experience in treating those other diseases impacts your decisions, side effects, racial profiles, sexual age profiles, et cetera. And then pregnancy questions also fit into this. So there's a lot to discuss. We go through a lot of trial and error when working with patients, sometimes for years. And this is, in fact, the doctor-patient relationship. So when we come to the point where we want to prescribe a biosimilar, it's on the basis of informed consent, risks and benefits, options that are there, and we come up with a treatment plan jointly with the patient. So this very process makes us conservative to many ways. The Hippocratic Oath, which has been around for almost 2,000 years, first do no harm. So do what needs to be done, do it properly, inform the patient with what's going on, and be careful just jumping in head first. We want to make sure that people have access to good information. So someone who has very severe disease may jump into a new treatment because you're up against the wall, so to speak. Those on the milder end of the spectrum may choose to go with what's been used before. So these patients are not identical, have different perspectives on what's going on, and the physician and patient come to a joint decision. When you want to switch a patient, physician-led switching, in other words, physician and patient combined decision to switch to a biosimilar, we're comfortable with that idea. Non-medical reasons and medical reasons are both involved. If you feel that a biosimilar may be better, but since they're basically the same idea and the same medicine, what we're talking about then is cost savings, co-pays, things like that. And physicians are comfortable benefiting the patient if they feel that the patient's going to have a lower copay, et cetera, maybe have better access, easier access. We're very comfortable. And if you look at over this 5-year span from 2016 to 2021, 2/3 to 78% of physicians were comfortable. Physicians are divided on physician-led switching for non-medical reasons. Non-medical reasons are things like cost and coverage determinations, co-pays for the patients. It's simple to make a decision if there's an obvious benefit, but since we don't have a lot of experience in the United States, we don't have a large number of people that are uncomfortable. At least that's the interpretation. In the EU, for instance, in 2019, 58% are uncomfortable with the idea of non-medical switching, even from the physician standpoint. And Canada and Latin America also have a high percentage of people who are uncomfortable doing this. And these are things that we need to look into. particularly since perhaps they have a larger experience with the use of biosimilars. There's also such a thing as third-party non-medical switching. In other words, the physician and patient don't decide whether to change the medication. It is in fact done at the pharmacy or infusion center. You go in and they say, well, your benefit says that you're supposed to be on a different medication. This will perhaps save money, but maybe not for the patient, but probably increase profits to the insurance carrier or drug manufacturer. So there's this non-medical clause that you will switch. These are not generics, as I said, but they're similar copies to the original. So while we're comfortable doing it as a new patient, switching stable patients we're uncomfortable with, particularly since there may not even be notice. And it's often at the last minute when you show up for your medication, you get surprised and you have this switch going on. So most physicians are not comfortable with third-party non-medical switching. Okay, 60% in the United States, and truthfully in Canada and EU, 64 and 58% are not comfortable with this. This is something that should be taken into consideration in your advocacy efforts. Physicians who have that due diligence responsibility to keep patients safe and to do what's right are uncomfortable with the idea of a switch created by a non-participant in the discussion for non-medical reasons. And this is something that we can look into and need to look into, and patients are part of the decision here. Forced switching is done when you don't have a say in the matter. In other words, you'll go in and say you have a choice, to all or nothing. You're forced to switch to a biosimilar medication. And physicians in countries such as in Australia and Canada have this. They have very strong opinions and oppose this practice. Australian rheumatologists have long opposed the practice, and in fact actually have a brand substituted not permitted option in prescribing. And if you look at the underlined area on the slide, the ARA recommends prescribing by brand name and clicking the brand substitution not permitted so that there is certainty as to what's actually being prescribed to the patient. Very strong position by a professional organization. 53% of Australian physicians want clinical trials and data to show that there be no loss of safety or efficacy. So this goes back to that due diligence and responsibility of the physician to show the patient what's going on, to be able to discuss the risks and benefits. And without that data, there's a discomfort level with saying this can be done without review. 81% want the switching studies before permitting automatic substitution from a biosimilar to a second biosimilar. So there is, in fact, two things that go on here: the originator to a biosimilar and then switching to a third product. So switching to one product is one thing, but going on to a second or third product indirectly is really something that physicians do not want. Canadian gastroenterologists issued statements opposing forced switching in Alberta and British Columbia. The Quebec government found that physicians they consulted opposed the practice, but implemented the forced switching policy anywhere. If you look on the right side of the slide and highlighted, non-medical switching in patients being treated with a reference biologic, the innovator product, is generally not accepted by learned societies and the consulted clinicians. So these are very strong statements, as noted here, and need to be taken into account. Again, the Canadian physicians also want switching studies before there's any automatic substitution. Prior to deciding whether automatic substitution should be allowed, those surveyed, do you believe studies should be conducted? 82% said yes. In the United States, we have an additional category called interchangeable biosimilar. So in this category, additional data is required to show that there is no worse outcomes, harm, or difficulties in switching between the biosimilar and the originator product. These products are allowed to be substituted at the pharmacy without prior notice. So are physicians more or less likely to prescribe interchangeable biosimilars? Yes, more likely. More or less comfortable with pharmacy substitution? Yes, but this additional data provides that level of comfort to the physician and the patient in their joint decision. In the US survey, additional data switching studies questions, would that make you more comfortable? 59, almost 60% said yes. Are you more or less likely to prescribe an interchangeable biosimilar? Again, 57% more likely. Some people are not sure, in the middle, the third, if you will, and then some people, of course, are less comfortable or less likely. But this data again shows that switching studies give us a level of comfort. And that is, in fact, the typical physician position. We'd like to see data. We don't jump in head first. We want to be able to discuss the position with our patient. And without data, we're not sure what the basis for the decision is. When you ask how important is the ability to indicate do not substitute when prescribing, across the world, Latin America, Canada, EU, and the US, 70 to 85% of physicians feel it is critical to the world's physicians that we're able to prevent third-party substitution that we feel is medically inappropriate. Physician and patient choosing which biologic to use or whether to switch, again, if you ask, it's very important or critical that the physician and patient decide which treatment option is available or should be used, as opposed to a third party, such as an insurance carrier or pharmacy benefit manager. In the EU, again, there's a longer history of using biosimilars. So perhaps, you could make the argument, perhaps in the United States, we just don't have the experience yet. And, what happens as you get more experience? So if you look on the left, sole authority to decide treatment, in 2013, 24% of physicians felt it was critical, 48% thought it was very important, or again, 72%. But after 6 years, 40% felt it was critical, 42% very important, essentially the same, but a rise of 10%, of 82% of physicians felt it was important that the physician and the patient control the treatment decision. So experience has reinforced the position that these kinds of data need to be there so that we can control what is being dispensed to the patient. Should there be authority to prevent a substitution, a yes and no ability? 84% consider authority to prevent a substitution very important or critical. This is an increase from 74% in the 2013. So this is very similar to the prior slide. Again, experience has reinforced this position. The next question is, should there be a choice? Physicians don't have problems with choice. Remember, we said that many physicians would prescribe a biosimilar to a new patient, but those who are stable on a product, should they be able to stay on it? And then if you have a choice of products, is that better than no? In other words, there's maybe perhaps one better, the other, different clinical experiences, different patients. So when you ask the question, European and US physicians agree, it's very important or critical that payers, both public and private, reimburse and cover multiple products, the originator and biosimilars, as well as different biosimilars. So it's not a problem with choice, it's a problem of having different choices available. Again, it is very important or critical that payers, public and private, reimburse products when we're looking at factors other than price. It's not the only factor that should be there. Again, patients are diverse, practices are diverse, patient experiences and prior uses are diverse, and how can you possibly create a checkbox system in a simple pharmacy benefit when you show up and say, how do we do this? So looking at a couple real world examples, this is the US Veterans Healthcare Administration data. They recommended switching patients from the originator biologic infliximab in this particular study to a preferred biosimilar. So they treat over 9 million patients in the VA system. So there's a broad base of data here. So they looked at 7 years, and patients with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, Crohn's disease, ulcerative colitis, and other conditions, they matched 838 people who were switched to 849 who didn't, the continuers. Those who switched from the product to a biosimilar were almost 3 times more likely to stop treatment and 5 times more likely to switch to a different product altogether after that original switch. So this is an unexpected thing. They did not continue as usual. That is a big difference in the outcome from those who continued, from those who were switched. 91% of the patients who stopped the biosimilar actually switched back to the originator product. So while they don't disclose or know the reasons for discontinuation and switching, there is in fact a big speed bump, if you will, in the treatment of these patients. There's disruption, undoubtedly more cost, both to the patient and the system in switching back and forth. Other studies in other areas, while it's not included in this study, show also more hospitalizations and more expense for diagnostic tests, et cetera, because people that come off of their medications often relapse. In Iceland, and this is another example in that we focus on the medications, but oftentimes we don't focus on the dispensing products, the binders, and the way things are dispensed. We only focus on the medication. So in the Icelandic National Health System, they switched from adalimumab to a preferred biosimilar. And these are injectables. The patient gives themselves an injection every 1 or 2 weeks. The medicines were very similar, but the injector pens themselves were different. So they looked at 198 patients with different diagnoses. 47% of those with the biosimilar pen said it was more difficult to use, although a few, 13%, found it easier to use. 24% found the biosimilar pen grip more difficult, particularly those perhaps with arthritis and things like that. A large number felt there was no difference, but those differences are important to the people who are unable to take the medication. The former Surgeon General, Dr. C. Everett Koop, once made the comment that the best medicine is the one the patient will actually use. So when people have difficulties with medications, there can be problems. So while the needles on the pens were the same, the grips were not, and 62% found that the injection needle itself was more painful upon insertion. There was a burning sensation during and after the injection, and that was felt likely to be due to the citrate, which was taken out of the original product, but left in the biosimilar. So again, the experience of the patient is not the same, and this can lead to more expense, discontinuations, and disruptions of care. So what are the takeaway points then? From the physician standpoint, the physician-patient stakeholder experience, we're highly confident in the safety and efficacy of biosimilars, but we're worried more about switching. There's no problem with new patients. We're divided about switching a stable patient to a biosimilar, particularly for non-medical reasons. A significant percentage, as we said, are not comfortable doing this. We're cautious about unnecessary switching. Patients who are stable on their current treatment, it's not one size fits all. I gave a couple of concrete examples, and we want the data that shows that we can do this. Third-party switching, in other words, driven by profit or monies to different parts of the healthcare team or stream, if you will, are something that we want transparency on. If we're going to make treatment decisions, we need information. These sentiments are strongest among European physicians. They're the most experienced with biosimilars, and they have more familiarity perhaps, but yet this has reinforced the idea that we need to be careful and the physician and patient should be in charge. We also want multiple products available, covered and reimbursed, so that there's an options for the patient and the physician to choose from. The survey data that I've shared today is just our most recent survey compared to some of the prior ones. And as an advocate, I think it's important for this information to be out there for you. These data are available on the website where you can see under surveys. I want to thank you for your attention and good luck in everything that you do.
Thank you, Dr. Mckibben, for giving us a snapshot of how the world's physicians feel about biosimilars, and especially about how and why patients are being switched between different biologics.